Now, first slide again. What are the common driving injuries I told you? Barotrauma of descent, ascent, decompression sickness, immersion pulmonary edema, oxygen toxicity, nitrogen narcosis, right? So, descent we have seen, and pulmonary edema we are not going to see. It's going to be a simple pulmonary edema only. Conservative management is more than enough. So, now we are going to see the ascent. Barotrauma of ascent means you need to write about the alternobaric vertigo, pulmonary barotrauma, arterial gas embolism, and decompression sickness. Decompression sickness is very important, which is once asked recently. So, what is alternobaric vertigo? Okay, during ascent, when the patient coming from down the water to the surface, that is from high pressure to a low pressure, what will happen? The air will expand, right? So, air will expand as the pressure decreases. This is all you need to know about ascending pathophysiology. So, air will flow through the ostia of the sinuses, and expanding air in the middle ear will open up the eustachian tube. Okay. So, what they are trying to tell? They are trying to tell that, see, this is the middle ear. Okay. So, he has achieved equalization at the 100 feet depth, right, by various maneuvers. So, now he has this much amount of volume. When this guy comes to the surface, the same middle ear box, the cavity is going to be the same, but the volume of air is going to expand twice. There will be a lot of air here, right? There's so much of air into the middle ear cavity. So, what the body does, it will open the eustachian tube, and through the eustachian tube, it will let out additional air. So, the patient becomes normal. Okay, the same is true for sinuses. For example, at 100 feet depth, the frontal sinus will be filled with some air. Okay, so imagine that he has already maintained equilibrium. So, now this guy comes up to the surface, right? So, whatever air is present here is going to increase in volume. So, there is going to be a lot of air in the sinus. So, what the body does, it will open the sinus ostia and it let all these extra additional air outside to the nasal cavity. Okay, this is a normal mechanism. Now, the question is, what if this eustachian tube is blocked? What if the sinus ostia is blocked? So, this additional air in the particular segment, let it be the middle ear, let it be the sinuses, it's going to cause a lot of trouble. Okay, this is called as a barotrauma of ascent. Okay, you got the concepts? So, during ascent, air will expand as the pressure decreases. Air will flow through the ostia of sinuses, and the expanding air in the middle ear will open the eustachian tube. Especially, this is what happens when you take off in an airplane, right? So, you are sitting in the airplane at the sea level. So, now suddenly it's going to the higher area where the pressure is very less. So, in your middle ear, whatever volume of air is present is going to be doubled or even tripled. So, that part that will cause severe pain in your ears. So, when you open your eustachian tube, the extra air will flow through the eustachian tube to outside. Okay, so you will get equilibrated. That's what happening when you take off in an airplane, right? If air be trapped temporarily in one middle ear cavity, okay, the pressure differential may cause unequal vestibular stimulus in the brain, resulting in vertigo. This is called as alternobaric vertigo. This is usually transient and generally requires no specific treatment at all. Second is pulmonary barotrauma. This is what I told you. When the patient is there at the depth of 100 feet below the sea level, say this is the volume of air. When he is suddenly coming to the ground level or the zero sea level, this volume of air is going to expand. Okay, if he is coming with a closed glottis, then this expansion of air, the expand of air in the lungs is going to cause pulmonary barotrauma. So, air expands within the lungs with ascent. If the diver ascends with a closed glottis rapidly in panic fashion out of air ascent, the expanding air causes parenchymal lung injury. This is called as pulmonary barotrauma, pulmonary overinflation, or burst lung syndrome. Okay, this is all again a very important question. Burst lung syndrome can lead to pneumomediastinum pneumothorax. Okay, pneumomediastinum is going to be very simple only, not so life threatening. Conservative management is required. Pneumothorax on the other scale also. If it's too much disturbing, then the standard treatment, how you handle a pneumothorax, whether it's going to be needle thoracostomy or a tube thoracostomy, you need to do it adequately. But of course, understand, if you are subjecting this patient under HBO, then you need to relieve all these pressures. You need to put an ICD, take the pneumothorax off, then only you can subject to any type of pressure effects. Okay, if the air enters the pulmonary venous circulation, okay, there's more amount of air. If it's not able to come out through the ostia or the eustachian tube, if this enters into the venous circulation, it can get embolized into the arterial system as well. Okay, the most sensitive end organ to such embolization is the brain. This is called as cerebral arterial gas embolization. It is called as arterial gas embolization. From now onwards, anywhere here in our seminar, when you see AGE, it means arterial gas embolization. Okay, and moreover, any neurological symptom or sign referable to the circulation of CNS A patient who is coming from down, that is 100 feet down or 33 feet down, from there is coming to the sea level, then is there anything that is concerning with the CNS circulation in setting of barotrauma, then it is cerebral arterial gas embolism unless otherwise proved. Okay. Now coming to the decompression sickness. For even the cerebral arterial gas embolism also, is going to be conservative management only. You need to stabilize the patient till whatever the embolism is present is going to slowly come out of their circulation. Okay, because once it goes to the arterial embolization, it can go to the venous side and it can slowly wean off or get absorbed. If still is not getting observed, then you need to recompress it. You need to go for recompression maneuvers where your HBO can help you.